Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, MMA community. My name is Anushka Raja. I am a TA in the MMOA division of the Institute of Clinical Excellence. Today, I'm going to talk to you a little bit about Parkinson's disease and Parkinsonisms in light of it being Parkinson's Awareness Month. But first, we're going to talk about what we have coming up in MMOA division. We will be in Aiken, South Carolina, April 15th through 16th. And then April 22nd to 23rd, we'll be in Florida and Arkansas. So look into live courses if that interests you. And then as well, we have April 26th will be the beginning of our Essential Foundations. And then May 4th will be the beginning of our next Advanced Concepts group. So lots of things coming up to you soon from the MMOA division. Okay, so what we are going to talk about is the 4 different atypical Parkinsonisms. To be diagnosed with Parkinson's disease, someone must have 2 of the 4 symptoms, including rigidity, bradykinesia, so slow movement, tremor, or postural instability. In addition to that, they have to have a robust response to levodopa therapy, which is the standard medication for Parkinson's disease. And you can't explain their symptoms from anything else like a stroke, antipsychotic medications, or atypical Parkinsonism disorders. So that's for Parkinson's disease itself, which a lot of us see that no matter if you're in a neuro setting or in a general outpatient ortho, you'll also get patients with those diagnoses come through, which is why it's important to be able to distinguish if maybe they're presenting with some other symptoms that are not the typical Parkinson's disease that we're thinking of. So atypical Parkinson's progresses faster, symptoms present more symmetrically, and are not as responsive to levodopa typically. A DBS, a deep brain stimulator, will make the symptoms worse, and there's a lot of overlap with symptoms, making clinic diagnosis a little challenging, but really good reason to tease these out. And then if you don't know some of these, you can always refer out to a neurologist or even a neuro-informed PT. So we'll talk about progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, and dementia with Lewy body. So progressive supranuclear palsy, or PSP, there are some things that you're going to look for with that. One is you typically do not have the resting tremor that you might see in other atypical Parkinson's diseases. You have eye movement abnormalities. So you might see a loss of downward gaze, and you also might see an increased instance of patients falling backwards or retropulsion. Something that you might additionally see in terms of just walking is they have a broader base of support or wide gait, some ataxia, so just a little bit decreased motor control with that pattern. And then their arms might be abducted like this. Something else with the speech is you might have not just like a decreased tone with hypophonia, which you see in Parkinson's disease, but you might have a hypokinetic dysarthria, so a change of how they're able to move their mouth. So that's PSP. One of the biggest things I look for personally is that lack of downward gaze and more instances of that backwards fall. You might see that just a little bit more with this group. Then we'll look at multiple system atrophy. So a big one that you're going to see with this is autonomic dysfunction or early dysautonomia. One best way you're going to catch this is taking vitals, which is something that we talk about often in our courses, is vitals are vital. But you'll see that fluctuation with blood pressure more often with this group, especially with the orthostatic hypotension. So getting dizzy upon changing a position. You might also see just general ataxia, and then you can see dysmetria. So like if you're tapping to the nose, you might see a little bit of overshoot or undershoot. You might have a difficulty if you're doing like drawing figure 8 with your foot, difficulty coordinating that movement. With eyes, you might see a little bit more nystagmus. Something else you might see with this group is cold hands or feet, and then redness in their hands, just because of how their autonomic system is regulating. You might see Pisa syndrome, so more of that forward flexed posture or neck flexion, and that's just your more atypical abnormal postures. You might also hear more of a choking sound when they're breathing, and they might actually have more signs of hypoxia and will eventually need a trach. Something else is you'll see more drooling and just drop in blood pressure. So for me, the biggest things when I'm looking for multiple system atrophy, just that looking at the blood pressure and how they're changing with that. Granted, we have other reasons that people's blood pressure changes or that we find orthostatic hypotension. So not necessarily the only factor that you're looking at, but just something that I see more often as like a trigger to think deeper with these groups. And then also the drooling. Okay, so we're going to talk about Lewy body dementia next. And this is also a good reminder that they might come in with a diagnosis of dementia or Alzheimer's and present with the physical signs instead that might throw you into thinking maybe more Lewy body dementia. So dementia comes before the motor signs with this group, which is why they sometimes come in with that diagnosis of dementia instead. But then you'll also see just different levels of attention and alertness, and their cognition might change, especially like varying through the day. And they might have some behavioral changes that you aren't typically going to see with someone with Parkinson's disease. Something really big hallmark sign is visual hallucinations. These people might see something that's a little bit more frightening, or it might be something just like they see some bugs in a room. So really important thing to ask patients about when you're doing an evaluation of someone with Parkinson's disease or dementia is if they have hallucinations. And then also just like how frequently they're having them and if they're on any antipsychotics for it. This group will have a harder time with the clock drawings because of their visual spatial reasoning. So this might be something that a speech therapist might come up on, or someone that's doing the MoCA might come up on more readily because they have that clock drawing in there. But just another thing to tease out for you. And they just don't have as much benefit from the levodopa treatment as well. For this group, my biggest thing is looking at visual hallucinations. We have other medications that can cause this, but just a way to tease out from the rest and dig further. All right, so corticobasal degeneration, or CBD, is the least common of these 4 atypical Parkinson's diseases, but still important to know about. You're going to have a little bit more of asymmetrical rigidity and bradykinesia, which is something you see more in the typical Parkinson's. But you might see something, what we consider as alien limb disorder, which their arm will move kind of out without prompting. And then apraxia, or difficulty, just difficulty on command of how to do an activity. They might present with a stereognosis or difficulty with 2-point discrimination. And this is like the only group that we really see that in, so a good way to tease it out. And then they might also present with myoclonus, or quick jerky movements. Something like finger flicks is something that you might see with this group as well. So really, it's really just important to make sure that we're able to recognize that there's something different, that's something off. You might hear that the patient is not responding well to their carbidopa levodopa, and needs something, just refer to their neurologist and say, hey, like, this is what we're seeing. This is what they're saying is not working for them. This is what else they're saying is happening to them, and really advocating for our patients that come in and get them that further treatment. I think it's getting diagnosed more often and more recognized with these atypical Parkinson's Your patient might come in saying that they had like a Parkinsonism or Parkinson's plus, and those are all within this type of group, but they're just different names for them. But then they will go further, the doctors will go further in to figure out which one that they have and how we can best help these people. So, quick summary, things to really remember are atypical Parkinson's progress faster, symptoms present more symmetrically and are not as responsive to levodopa. A deep brain simulator will make that symptoms worse. And there's a lot of overlap with symptoms. So just making sure that we're teasing out what we can, giving neurologists as much information since we are the ones that see them more frequently and get to spend all that time with them and ask them so many questions. So just a good way to advocate for their patients. All right. If you have any questions, please feel free to reach out to me. A great resource for this, honestly, is NeuroSpark with Claire McLean and Aaron Hirschberg. And then another thing is we talk about these 4 more specifically in advanced concepts as well if you have more questions within the neural population. But I hope you have a lovely rest of your night, and thank you for joining me today.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.